8 o'clock. We should start.
Okay.
Yeah.
All right, great. All right, great. Good evening. This is Dr. Sudhakar Janalagadda, President of National AAPI. Today we have a very exciting webinar on update of cardiovascular manifestations of COVID-19. We know we did several webinars in the past, last 6 months about cardiac diseases related to the COVID-19. And today they're going to bring back and see updates on manifestations of COVID-19. And we have very much eloquent moderators today, Dr. Sunil Kaza. Dr. Kaza is interventional cardiologist from Nashville, Tennessee. Also current regional director for National AAPI, a past president of local chapter of Nashville AAPI. And Dr. Gunjan Shukla is a well-known cardiologist in New Jersey area. Gunjan is electrophysiologist and also director of atrial fibrillation ablation unit. And he's the current president of BJ Medical College and also vice chair of National Alumni of AAPI. Welcome both. And Sunil, go ahead. Thank you.
I think Dr. Shukla will start.
All right. Well, thank you very much for introduction. And I want to welcome everybody for our cardiovascular seminar under Dr. Janalagadda. And we have excellent faculty today, and I'd like you to enjoy and also gain a lot of knowledge from the faculty. It is my great privilege to introduce our first speaker, Dr. Indranil Basure. And most of you know him very well. He's a very well-known cardiac electrophysiologist, one of our own. And Dr. Basure is a staff at Memphis Veteran Medical Center in Memphis, Tennessee. Currently, he's also an adjunct professor at the University of Memphis, Tennessee. He also has an appointment at All India Institute of Medical Science in India. One thing we share with Dr. Basure that we both went to the same electrophysiology training at Beth Israel Deaconess Medical Center at Harvard Medical School under Dr. Mark Josephson. And I also went to the same fellowship. And so I know that he's very, very well trained and he's already very well known in his area. Dr. Basure has numerous research publications, numerous teaching appointments, and numerous clinical trials. Another good thing about Dr. Basure is that he's very good in meditation, and he can basically help us all in this kind of environment with meditation. Today, Dr. Basure is going to talk about updates of cardiovascular manifestation of COVID-19. Dr. Basure, welcome.
Thank you very much, Dr. Shukla, for the excellent invite. I'm not really sure if I deserve all those. Without wasting much time, let's go dig into some of the latest thing that has come up in the last few days. So around 2 weeks back, we have an MRI study from Germany that is really, really worrisome for cardiologists. So they took 100 patients, all of them had COVID-19 by RT-PCR approved. 2 months after having COVID, they did MRI on all these guys, and they found 78% of them had cardiac involvement. The funny part is, and that's what is worrisome, is 67% of these guys had minimal to mild symptoms, just some cough, some nasal drip, that's it. And they didn't have to go to the hospital, and they were the majority. Some of them even played things like golf, were skating, and other aggressive stuff, and they had no problems at all through the whole course of their COVID. And one of them actually did ice rink skating, which is interesting, but that's why I just put it up. And that obviously requires both energy as well as the fineness of your arms and legs, blah, blah, blah. Long story short, 78% of them had cardiac involvement, which varied from having myocarditis, which is inflammation of the heart. Almost all of them had troponin, that is the cardiac enzyme, raised, and almost all of them had three different things. So one was increased enzymes. Number two, they had evidence of myocarditis, and that was of different extent. 3/4 of them had some sort of heart failure, and I'll explain what I mean here. For cardiologists and for the common person, the heart failure is slightly different, but I just wanted to bring this up. So they took cohorts which were complete controls, healthy people. Now these guys are also super healthy, though they had COVID, but they were all super healthy people. But the average EF of the super healthy guys who did not have COVID were much higher, 5 to 10% higher than those young guys who, as I said, did ice rink skating and did all sort of aggressive stuff, playing football, but had COVID. So looks like there is some amount of myocarditis involvement in most cases of COVID. Now, the other important thing that is important to understand is that exercise capacity in most of the people were less when compared to age and sex match people. So this is one striking thing. I'll go a little bit about this when I talk about the symptoms. The other very, very surprising thing is completely new, and that just came three to 4 days back on April 14th. Both CDC and WHO reported. As you know, for the first 3 months when we had more than 1 million cases, now we have 5.5 million cases. There were only 1,200 plus people who were kids who were really admitted. And most of them did not need ICU admission, because they said that COVID really didn't affect kids that much for different reasons, which we'll not go into today. There are very few ICU. There was a study of 63 kids from 6 different periodic hospitals. None of them, all had sort of moderate COVID. None of them had to go to ICU. Now this has changed. The April-August 14 says 1 in 3 children who are having COVID now are needing hospitalization. What has changed, we don't know. Is the burden of disease more? We don't know. Is the amount of exposure to the virus is more? We don't know. There is some paper, 2 of them are non-peer reviewed in medicine, and 1 of them is peer reviewed from China, which says the amount of virus you get, and that's why possibly, though it's not proved, most of the guys who died in northern Italy was among doctors were anesthetists, because they had intubated these patients. So could be the amount of virus involved made a difference. So these are the 2 very important studies that we need to understand. So first thing is, if you have COVID, doesn't matter how young you are, doesn't matter if you have no comorbidities, you have to be followed by a cardiologist to make sure that you get out of myocarditis, you get out of heart failure. Now, what is the range of heart failure? The range of heart failure for having below 30 or 25 EF, which we call pretty bad heart failure, that's thankfully pretty low, unless you have what is known as you know, there are 3 tracks for COVID: mild, moderate, severe. Most of the guys with severe have that sort of heart failure, whereas moderate, 90% of the moderate have 5 to 10 millimeter fall in EF, have some symptoms of heart failure, might have no symptoms of heart failure, though echo-wise they have a decrease in heart EF. So that's one good thing. Symptomatology-wise, acute symptoms, yes, you can have what is known as myocardial infarction. So there are 2 types of troponin rise. One is ischemic, which is because your arteries are blocked by large thrombus formed due to COVID. Similarly, you can have stroke with main arteries, not the small arteries that generally happens. The main arteries being blocked, the MCA, ACA, and all those arteries. Similarly, you can have the main arteries blocked. In fact, there are a report of a 30-year-old guy in New York that left main blocked and died instantaneously, even before 911 could come. Autopsy showed left main blocked. So that's the acute symptom that you get. But most people, 80 to 85%, actually present with nothing more than what looks like a normal pneumonia. They are normal influenza. They just have symptoms of fever, feverishness, slight cough. They might have slight breathing problem. That's it. Now, we know based on the recovery study in Oxford that if you have diabetes type 1, the chance of having moderate to severe COVID is highest. They are the highest risk. Then comes diabetes type 2, and then comes people with only hypertension. Now, what does the mixture have? We really don't know, but it's somewhere in the range between type 1 and type 2, I believe, based on the study, because Oxford did not have the amount of to decide that sort of population because of the lack of a cohort in that particular study. But what they do know is that if you're type 1, it doesn't matter what age you are, you're highest. Having said that, those who are below 40, they tend to have a more milder course despite having type 1 of diabetes. So symptom-wise, the other important symptom is anosmia, that is lack of smell. Some people have lack of taste also. Now, it's important to understand almost all upper respiratory tract virus infection can cause anosmia. And that's common. Every ENT guy will tell you that. Only difference is in COVID, amount is much more. In China, they reported 67%, whereas in other places, it is reported between 15 to 32%. I don't know what is the actual figure. I have tried to find out a figure for America. Unfortunately, I did not get it. Most of the reports were coming from China, but that, so obviously, if you have that, the chance of you being COVID in a COVID pandemic is more than having normal influenza, though you still might have just plain simple influenza also. So that is the other important thing to understand. Now, fever is the commonest symptom, but there are two people who may not get fever. Number one who's elderly. Elderly people might not have enough interleukin-1 produced or enough what we in common terms call as pyrogen produced, so they may not have it. And the second is cohort with immunocompromised. Certainly, we don't have tons of HIV in common population, but if they do have HIV with high counts, they may not have. Now, there has been no report till now, people with severe diabetes who are also immunocompromised, not having fever, but that is a possibility that we have to keep in mind, like people with severe uncontrolled diabetes, end-stage renal disease, severely elderly, they may or may not have fever. The other important thing is also abnormal is diarrhea. Again, two types of people have it. Young kids can produce only diarrhea. They may not have any of the upper respiratory tract symptoms. Similarly, elderly people can produce with recurrent diarrhea, and that may be, unfortunately, the only symptom, though it's pretty rare, but can happen because remember, GI tract does also have endothelium, does also have ACE2 receptors to which the virus attaches, though obviously concentration is way less than the heart and the lungs, but just like almost every organ, brain, they can have it. The other causes of death, which is very common, is stroke. And unfortunately, the stroke involves large vessels, and that's a problem. Cardiac-wise, there are a couple of other things that I said. One is myocarditis, as I said, because of the virus or because of the cytokine release syndrome. And there's one study that is very informative, and I'll just tell you about that. So they took 14 people who had in New York who all died. And unfortunately, they were all elderly people. They did biopsy. In 22% of those cases, they had actual virus in the heart that was replicating by PCR, but they had no myocarditis. Whereas there were people, 32 to 33%, I don't remember the exact statistics, who did not have virus in their heart, certainly no replicating viruses, but they had mild to severe myocarditis. So that's important information. Number one, that means that people with you can have myocarditis for two different reasons. One, myocarditis secondary to the virus itself. Secondary, you may not have virus at all, but still have myocarditis secondary to your cytokine release syndrome. And we know that both interleukin-6, interleukin-1b, TNF-alpha, all causes myocarditis because most of the cancer drug, daunorubicin, doxorubicin, actually, by blocking the HER2 receptors, can stimulate TNF-alpha, which causes myocarditis and fall of EF in cancer patients. So it could be some sort of though we don't know exact pathology, but long story short, even if you don't have virus in your heart, you can still have myocarditis, particularly if you have severe disease, and that's possibly exclusive to the fact that you have cytokine release syndrome. Last but not the least important, that most of the people, and again, I don't remember the exact percentage, but it's a big majority, almost 65 to 70%, can and have seemed to have increased tachycardia. The heart rate is increased even at rest for a couple of weeks post-COVID. And there's something that is coming up brand new. We don't know the pathology, and that's called the late COVID syndrome. So late COVID syndrome is still in the making as to what it really considers. People are trying to find and understand it. So one of them is severe fatigue syndrome, where you're severely fatigued for no reason. You had COVID months back, everything is negative for months, you have nothing, but you're still superly fatigued, almost like chronic fatigue syndrome. The other is these people, some of these people has been shown to have low level of myocarditis, and some people have shown lower EF. Now, so I guess Dr. Chandra will give us more understanding on that when we need to do echo and other stuff to follow these people. So if you do have had COVID for a long time before, and if they present to a cardiologist, I think it makes sense that not to just take that as a rheumatological disease, or even somebody who's diagnosed as a chronic fatigue syndrome person, especially if they're newly diagnosed, it may warrant more extensive investigation than not doing it. The last point, I don't think I don't have much time, is that I wanted to bring out is the fact that most people with COVID, thankfully, don't have symptoms. But again, as I said, based on the German MRI study, despite that, 78% of them have MRI evidence of cardiac disease. So if somebody has COVID, if your patient had COVID, or maybe the son of your patient or daughter of your patient had COVID, please ask them to come and see you too, though they do not have actual cardiac disease, because you might have long-term sequelae. We don't have just 352 days from the so-called first day in China. In America, we are 311 days, but so we are still pretty early. So we don't know what the long-term sequel will be, number one. Number two, if at all there'll be a long-term sequel. But the fact that some people have been shown to have a EF reduced from 55, 60, which is normal, to as low as 40%, with markers indicating myocarditis increase, plus the cardiotoxic cytokines, interleukin-6, can go up to as much as 15 to 20 times the normal level. And there's one study where they compared with cancer patients, it was like 5 times more than what cancer patients have who are on chemotherapy, but not necessarily on drugs like Don or Doxil, which actually are cardiotoxic. So that's the important thing, that we really don't know how long this interleukin-6 lasts in your blood if you do have it post-COVID. But I guess it mandates that every percent, doesn't matter how healthy is he, if he's planning to go up, if he has even gone up Mount Everest, he still might have cardiac problems and they need to be followed for long term. I will stop now. Thank you very much for this opportunity. I'll be ready for any questions if you guys have it.
Question and answers, we will push it to the end for all the speakers. That way we can have all the questions at the same time, and some of them maybe duplicate. Thank you very much, Dr. Vasu. And it's my privilege and honor to introduce Dr. Chandrasekhar as the next speaker. He's from PGI Chandigarh, currently Professor of Medicine at University of Minnesota and Chief of Cardiology at the VA Medical Center in Minneapolis. He is currently the Editor-in-Chief of Journal of the American College of Cardiology, Cardiovascular Imaging, and which is a premier journal in cardiovascular imaging. He's also Associate Editor of JAC, which is Journal of American College of Cardiology. He has been an active member of multiple grant review committees for leading research funding agencies in the USA, including NIH, and served previously as a chairman of the VA Cardiology Basic Science Merit Review section of the US Government Department of VA. He is also board member of Scientific and Policy Advisory Committee of the World Health Federation. He has many laurels like that. I can go on talking about him for next 2 to 3 minutes, but in the interest of time, since we only have 15 minutes for each of the speakers, without further ado, I request Dr. Chandrasekhar to take over. Thank you.
Thank you so much for the kind introduction. I greatly appreciate the opportunity to be here. I'll just quickly share my screen. Is it visible?
Yes.
Yes.
Okay. Okay, so in the next 15 minutes or so, I'll take you through the imaging world in the COVID era. There's a lot of information. One of the things I have to preface is a lot of this is changing very rapidly. So what we talk today may not be valid very soon. And we're finding that very commonly. So how do we think about imaging in COVID-19? As a general structure, we are worried about the effects on heart, and we think about it in two forms. There's a structural component to it and a functional component to it. The structural component has been described to be mainly acute myocardial infarction and a vasculitis, mainly an endothelialitis, which results in a thrombotic state, as well as an inflammation-related thrombosis. And that's why you must have heard there may be an excess of acute myocardial infarction with probably a significantly higher clot burden. The things that concern the imaging side of things are more commonly myocarditis or LV dysfunction, whether it is acute or chronic. And this is an area which is extremely nebulous. Uh, you just heard about the famous Puntman paper in JAMA Cardiology looking at the 100 patients who had recovered and got myocarditis on MRI. Although all of us talk about myocarditis being common, histologic evidence of myocarditis has been extremely rare. So a lot of our excitement about myocarditis has to be tempered a little bit with a lack of information on what is happening. We've all seen LV dysfunction in COVID, but there can be any number of reasons. And as I'll show you down the road, a classic myocarditis has to have two components. It has to have cellular infiltrate and cell death, and which is thought to cause the LV dysfunction. The cellular infiltrate has been variously seen, mainly lymphocytic infiltrate, and cell death has not been seen consistently in autopsy. People have tried to find virus in the heart, and that also has not been a common thing. It's very difficult to show virus in the myocytes. Some of the macrophages which come in carry a low load of virus, and so a classic myocarditis picture is highly debatable. The MRI study that we talked about, I'll show you something more down the road, will help us place this into perspective. On the functional side, we have seen effects of pericarditis, which is not uncommon in this patient. We have seen LV dysfunction, which may be just cytokine-mediated immunosuppression, and a bunch of other physiologic changes that can happen. We'll talk about it if there is time. So when we plan for our labs, we have to look at the question, when do we image? What do we image safely? And how do we image? It also depends on the time. When the pandemic was really roaring, our thoughts about imaging was a little different. Now that most practices are reopening their volumes and trying to ramp up to normal, the strategies are slightly different. And I was involved, I was the senior author on the guidelines about reopening that was published a month ago, and we'll talk a little about that. What to image also has been a controversial thing. Do you do a very focal study, like a limited study to answer a question, or do we do what we traditionally do, an exhaustive panoply of testing to answer all the questions? And there's some data about that I'll show you. How to image is also an issue and mainly involves what tests do we substitute that are safer than the tests that are not so safe. And finally, in all this confusion, we have not concentrated on this question, but I think that's the most important question for us to figure out. How does it help? What is it answering? Is it helping us with immediate treatment? It does in a certain small subset of patients. Does it help us in prognosis acutely as well as chronic sequelae, as Dr. Basu was mentioning? And what's the evidence of long-term damage and how do we look at it? So testing during the pandemic has three stools. It's like a three-legged stool, right? You need an appropriate patient and you need to have an appropriate question. So you'll try to focus your imaging to answer that particular question that you need at that moment. What is more tricky is what is the test strategy you do and how do you deploy it? For example, you need a safe area for testing. And when the pandemic was really rearing, people were wondering whether a transesophageal echo can be safely done at the bedside, or do we have to do it in a negative pressure room? There were lots of questions that we didn't know at that time. Some of this is getting clarified. The adequacy of PPE was an issue in the beginning, not so much now. We need to have social distancing in the waiting rooms, and that has resulted in us engineering a whole new way of bringing in patients into the facility. The three areas of controversy have been, should you do TE, because that's thought to be an aerosolizing procedure? What kind of PPE do you need? And the standard guidelines right now are you have to use the usual PPE, face mask, N95, gown, and try to minimize as much contact as you can. Treadmill exercise also has had some problems. It's thought to be aerosolizing, not as much as the other tests. And you cannot put a mask while the patient is on the treadmill because that limits their ventilation. So this has been tricky. Lots of labs have nearly given up doing treadmill testing except for very selected indications like transplant workup, or when you're looking at chronotropic incompetence, which often is not an urgent test to do. And then, of course, tech safety is a big issue. You probably might have heard in India now, there were two techs, echo techs, who died on getting COVID. Some of you probably practice in that area and know more than me. In our lab, two of the techs tested positive with COVID, despite all the precautions that we take, but luckily both recovered. And then lastly, the appropriate test environment, choosing the best possible test for the best possible question is important. We'll talk about it. How has it affected imaging practice? All of you have seen practice volumes go down. The biggest volume reduction has been in TE, but nuclear, which was the workhorse of most cardiology practices, especially in private practice settings, took a big hit. CMR went down. CT went down, but it recovered much faster than the other. The only area that really grew was point of care ultrasound. How does COVID present for imaging? So this is like a general paradigm that I use to tell my fellows and trainees on how to look at this. So if this is the curve of infection, there's early infection, peak morbidity, and improvement in the patient. It presents generally in 4 or 5 buckets of syndromes. You of course get acute coronary syndrome. You could get some rhythm issues, which could mostly be ectopics. Acute coronary syndrome risk goes across the spectrum, and all of you know the papers and literatures related to that. There's not much to image here. It's mainly a Cath Lab based issue, whether you take somebody to the lab or not. Rhythm issues have been a problem, especially recently in resuscitation. There has been a paper showing that sudden cardiac death resuscitation success is going down because providers are not willing to jump in as vigorously as they used to, and it takes time to get all your PPE up before you start resuscitation. And that is an issue, but there is not much imaging associated with it. Where imaging comes is in the group with hemodynamic instability, generally caused by either right heart failure, an excess of pulmonary embolism, LV dysfunction, as Dr. Basu talked, or cardiogenic shock. There is a portion of patients who present with stress cardiomyopathy or Takotsubo-like syndrome, and then we already talked about myocarditis. And then there is a whole set of chronic sequelae. So of course, in the acute coronary syndrome, cath is the question. But in non-acute chest pain syndromes, one of the theme that is coming out is maybe CT scan would probably be the better first test to rule out coronary artery disease with certainty. There's a big push towards this. The data seem to be favoring this. And this is one of the things we recommended in our guidelines. MINOCA, which is myocardial infarction with normal coronary arteries, CMR, is turning out to be a one-stop shop. These can be done very easily. There is very little exposure to the tech and the MD. And so this might be something that will take over. Then, of course, hemodynamic instability starts with point of care ultrasound and a limited TTE, where GLS is sometimes becoming important. I'll show you in a little while. And then, of course, if it is stress cardiomyopathy or myocarditis, CMR is coming. But don't forget, a significant proportion of patients is not damaged because of COVID, but we are unmasking previously present issues that were latent. And there is also this tricky situation of a person with fever, systemic inflammation, some random things found on the valve, whether it is endocarditis or not, is becoming a big issue. Here are some of the general things that we see acutely. You know, the CT scan kind of can progress very rapidly. You can have this crazy paver pattern, and then ultimately it fills up the lungs. Lung ultrasound, which is a low risk procedure, especially in people who are lying prone and being ventilated, is a very useful technique. Can be done quickly. And you can see these comets, which are supposed to be signs of interstitial edema and start of heart failure. And as it progresses, you can start seeing effusions, and these comets fuse together. And these are bad prognostic factors. The CT obviously is a good test. It can give you an early diagnosis of COVID and show you a number of things, including coronary artery disease, and an excess of pulmonary emboli are being seen. Echo is starting to show more importance of the right heart rather than the left heart. Right heart dilatation and dysfunction is turning out to be one of the strongest predictors of bad outcomes in patients with COVID. And then, of course, you can do a triple or a quadruple rule out. You can rule out the lung issue. You can rule out PE. You can look at the coronary arteries, and you can get some delayed enhancement occasionally. There was a paper in JACC Imaging by Gianluca Pontone's group. It said you could actually do all these four and avoid many other testing. And then, of course, MRI can show you myocarditis. Here is a paper that in JACC Imaging. Actually, this was a letter to the editor. And the surprising part is this got covered on CNN and nightly news and a ton of media. We were very surprised that a letter got this much output. One of the things it showed was the presence of right heart dilatation in a COVID patient has bad prognostic factor. And here was the second definitive study, which showed that global longitudinal strain, a reduced global longitudinal strain, is a really bad prognostic factor, both for in-hospital mortality and long-term outcome. This was the paper Dr. Basu was talking about. Here is an example of a patient who has inflammation in an endomyocardial biopsy, but the inflammation is limited to lymphocytic infiltration. They did a test called T1 mapping and T2 mapping, which showed that there was excess of T1 mapping abnormalities anyway 60 to 90 days after the COVID had recovered. And they found some evidence of pericardial effusion and late gadolinium enhancement in the pericardium. The issue here, this paper got a lot of attention, but the issue here is T1 mapping or edema by itself does not tell you it's myocarditis. It tells you something is wrong with the heart. You could get T1 abnormalities in pretty much any condition. It is like the troponin of CMR. T2 is a little more specific because it tells you about edema, but remember, a lot of these guys get cytokinemia, which can cause edema without a myocarditis syndrome. So the jury is out. There are two other papers which show that if you take endomyocardial biopsies at this time, you cannot find a lot of cell death, and finding virus in the myocytes has been nearly impossible. Here is something that may be of practical use for you. This comes from Mark Monahan's lab in the UK. We often have patients prone and ventilated, and it's very difficult to turn them up and get a regular echo. And one thing you can do is you can slide a transesophageal echo probe between the bed and the chest and get reasonable quality echoes without really having to disturb the ventilation pattern. So this might have a very practical use, especially in the ICU setting. And then you can also be a little far away from the patient once the probe is under the patient. There are two guidelines I would draw your attention to. This came in JACC. It hasn't been published yet. This is online before print, which takes you through how to manage imaging in patients with various syndromes of COVID. And here is the second guideline. This is the one I was involved in, which says, how do you reopen your practices once the COVID numbers start to come down? They are not completely gone, but how do you get back to normals? The general paradigm is when the COVID was really at peak, we were doing minimal imaging and only very judiciously if management is impacted. But now at this stage, we can resume. And how do we resume? This is what we see. So this is the table which tells you the common conditions that we deal with. And some of the highlights are here. In COVID, TEE has lost out significantly. Even in conditions where it used to be the standard modality for imaging, like LA appendage evaluation before cardioversion or before a occluder implantation, or for prosthetic valve dysfunction, we have downgraded that in favor of CT. CT is very accurate in excluding LA appendage clots. In fact, even before the COVID, a lot of practices, including ours, was moving into that direction, and we were completely avoiding TE. CT has kind of won out in this, especially for non-ACS related suspicion of CAD and chest pain. It's excellent, and it gives you a very high negative predictive value. It also surprisingly is very good at analyzing prosthetic valves. So that wins there. CMR, of course, is gaining a lot of value in MINOCA, new onset heart failure, and myocardial imaging, viability image. And nuclear, of course, for chest pain still remains. And it also is not a very risky test compared to stress echo or dobutamine echo. There is a whole table about PPE requirements. Those of you who are interested can look this up. So what's the take-home message? We are learning as we go, but remember, a lot of this data is changing very rapidly, and we have to think about it preliminary. Testing strategies are changing. Minimal testing is still an issue. And we are looking at one-stop shops like quadruple rule out on CT. And also remember, imaging needs to show an influence on patient outcomes now more than ever, because the risk of doing a test is high for both the technician, the MD, and the patient. Thank you very much.
Thank you, Dr. Chandra, for that excellent presentation in the given short time. We could listen to you for an hour about this. There's so much to learn from you. I would request Dr. Lokesh Idara to read the disclaimer of AAPI, please. And then we'll go with the next speaker after that.
Thank you. This is Lokesh Idara. It's an excellent program. Thank you all the speakers. I really appreciate it. AAPI disclaimer for teleconference on COVID. The services of the AAPI COVID-19 teleconference is for information purpose only, should not be considered as medical or financial advice. AAPI has no liability as to how this is interpreted, no liability for results, losses, damage that may be caused directly or indirectly or incidentally. Please refer to CDC website and your state government health authority for information updates. Thank you.
Dr. Shukla.
All right, well, thank you so much. The talks are excellent. Now it is my great privilege to introduce our next speaker, Dr. Shripal Bangalore. Dr. Bangalore is a very well-known interventional cardiologist. He's a professor in Department of Medicine at NYU Grossman School of Medicine. He's a director of Cardiac Catheterization Laboratory at Bellevue Hospital, Director of Research of Cardiac Catheterization Laboratory. Dr. Bangalore trained at Brigham and Women's Hospital for interventional cardiology. He is a primary investigator of multi-center international randomized controlled trials. Dr. Bangalore has over 400 peer-reviewed publications and articles. He has so far drawn about more than $12 million research grant from National Institute of Health, Agency of Healthcare Research and Quality, American Heart Association, and from industry. I can go on with Dr. Bangalore's credentials, but in interest of time, I'm going to introduce the topic. He's going to talk about management of acute coronary syndrome during COVID-19 pandemic. Dr. Bangalore, you have 15 minutes. Thank you.
Thank you very much, and thanks for that generous introduction, and thanks for having me on. So I'll see, can you see my slides?
Yes.
Okay, great. So, the one thing that I think this was a very nice introduction, and of course, I think the previous speakers and Dr. Chandrasekhar's talk were excellent and kind of leads into what I want to discuss in the next 10-15 minutes, which is more so specifically focusing on diagnosis and management of STEMI during the COVID-19 pandemic. And one of the things that I want to point out, I'm sure many of us who have been taking care of these patients in during the pandemic, we felt something like this. Like it's challenging. It's even more challenging in this COVID era. In New York, we were hit pretty early on, and we had limited information coming from China, but that's pretty much what we had. So as an interventional cardiologist, we did see a lot of patients, a lot of activation for ST segment elevation in these patients. So I'm just going to speak about these ST segment elevation in patients with COVID-19. We actually published this pretty early on, looking at our series of patients that we saw in New York. This is published in the New England Journal. And just to start with this, I mean, our publication was based on the first 18 patients we had. So all of these patients had COVID-19, confirmed COVID-19 and ST segment elevation on their EKG. And this was the final diagnosis on this particular patient. So we had the final diagnosis of ST elevation myocardial infarction in 44% of patients. And as Dr. Chandrasekhar was pointing out, the 66% of them were classified as non-coronary myocardial injury. I mean, this is, we've been using the somewhat of a loose term of myocarditis, but in this paper, we didn't want to use the term myocarditis because exactly for the reasons that Dr. Chandrasekhar was outlining, because there hasn't been any studies actually showing virus in the myocardium. So we termed this non-coronary myocardial injury, and the criteria was based on the fact that these patients had ST elevation on their EKG, but they either had non-obstructive coronary artery disease on angiogram or had normal wall motion on echocardiogram in patients who did not undergo angiogram. So I want to share some of the examples and see, can we actually use EKG to diagnose STEMI in these group of patients. So this is one of the first few patients we saw, a 52-year-old guy, multiple risk factors, but he came in with fever, cough, shortness of breath, very typical of COVID. He came in intubated in the ER, and these were his EKGs. And of course, right off the bat, you see that he has significant elevations in 1 and L, and also in his lateral leads, V4 to V6. And this was his second EKG. So after he was intubated, we repeated his EKG. Again, you see this persistent elevation in 1 and L. The elevation in V4 to V6 is not as prominent. Some ST depressions and in 3 and AVF. And of course, we took him to the Cath Lab. As you heard from the previous speakers, I mean, the first critical thing is to make sure that everybody in the Cath Lab is appropriately using PPEs. So we instituted a number of changes to the Cath Lab, including the fact that in addition to donning and doffing protocol for using PPEs, we instituted that any patient where we have less than 24 hours of contact, for example, STEMI patients coming from outside, we would consider them as if they have COVID-19. So COVID-19 suspicious patient, PUI, and treated them as COVID for the purposes of the Cath Lab. The other thing we instituted was we quickly got rid of patients needing to sign consents, and we used a verbal consent and clearly documented these in the charts so as to not to contaminate any of our equipment, paper, pen, etc. for signing consents. But anyway, so this is what we saw when we took him to the Cath Lab. Let me see if this actually plays here. So here you see that this is the right coronary artery. So the artery is beautiful, no obstructive disease. This is the left coronary artery again. It's almost angiographically normal, no significant coronary artery disease. And a couple more views of the same patient. Again, you see that his LAD looks okay. This is the spider view, LAD and circumflex. Again, no significant coronary artery disease. And this is the protocol we came for the doffing PPE in the Cath Lab. We call this the 10 by 10 steps for donning and doffing. And this is what we did. That was one patient where you see kind of like significant elevation in ST segments, but on coronary angiogram, not really much in terms of obstructive CAD. Let's look at another patient. This is a 58-year-old guy. Again, the syndrome of fever, cough, shortness of breath. But this guy also had chest pain. And this is what we saw in his EKG. So you see dramatic elevation in his STs in the inferior leads, 2, 3, ABF. You also see these, whatever we want to call this, reciprocal changes, V1 to V2, and also some elevation in V4 to V6. And this was his chest X-ray. So you see some infiltration in his left lung fields, something also in his right lung fields. And this were what happened to him. So he was presented at an outside hospital. We accepted him to the Cath Lab. But before they could send him to us, he had a VT, VFib cardiac arrest. He was shocked once. He was, he had return of spontaneous circulation. He was intubated, and he was shipped to our Cath Lab. Again, we had the full PPE on. This is what we did. We took a look at his right coronary arteries. You can see that there is a thrombotic occlusion of his right coronary artery. His left coronary artery has a significant stenosis in his proximal circ, but the rest of his left coronary artery was okay. So this guy had a STEMI with, it was an RCA STEMI occlusion of his RCA. And what we saw in patients similar to him was a heavy thrombus burden. I mean, I have multiple examples of patients. We have tons of clot, pretty much resistant to everything that we would do. In fact, we started using intracoronary TPA in some of these patients, but a significant amount of thrombus burden in many of these patients. But anyway, so in this particular patient, intracoronary pharmaco, 2B3As, etc., aspiration thrombectomy and stenting, and it pretty much looks good. And this particular patient did pretty well. He was intubated, he was extubated day 2, and he actually left the hospital 5 days later. I also want to remind, like in patient, the EKG criteria for ST elevation, if you have no left bundle branch blocks, these are some of the criteria that we use. Other than lead V2, V3, where you need at least 2 millimeter elevation, all other leads, you need more than 1 millimeter ST elevation. And of course, if you have criteria, as you all know, if a patient has a left bundle branch block, the Scarbosa criteria for diagnosing of MI in these group of patients. So the question we asked was, how can we distinguish between non-coronary myocardial injury versus STEMI in COVID-19 patients? Because I gave you 2 examples of patients where the EKG looked pretty impressive, but on angiogram we saw, in one case there was non-obstructive disease, in another there was a typical STEMI with RCA occlusion. And some of the things that has been floated around is maybe if you see reciprocal changes on EKG, perhaps may help distinguish non-coronary myocardial injury from STEMI. So in other words, if you do see reciprocal changes, is it more likely to be STEMI? I do have some case examples. So here is one of the example of a patient where you see ST elevations, and the ST elevation is pretty much in all of the most of the leads. I did post this on Twitter and asked people, do they think that there are reciprocal changes on this particular EKG? In fact, the majority of responders on Twitter said like there is no reciprocal changes. So in other words, if they were to see this patient, the people who believe in reciprocal changes would think that it's unlikely to be STEMI, it's more likely myocarditis or non-myocardial injury. What about this particular EKG? Again, you see this another patient where you see ST elevation V1 to V5 and almost in V6. So it is they present through all of the precordial leads. And the question is, are there reciprocal changes in this? And again, at least on Twitter, the majority, 92% of them said there are no reciprocal changes. Again, these are two examples. If you go by reciprocal changes, you would say this is unlikely to be a STEMI, maybe non-myocardial injury or myocarditis, whatever we want to call that. Interestingly, I also asked the question, which of the two patients has LAD occlusion? And the majority of them basically said, neither of these two patients have LAD occlusion, but in fact, these are two patients that we treated, and both of them had significant proximal occlusion. So in fact, even though there were no reciprocal changes, both of these were typical STEMI with thrombotic occlusion of their proximal LAD. So are there other things? So just to conclude, so in terms of reciprocal changes in EKG, absence of reciprocal changes alone does not rule out obstructive CAD in these patients. So how else can we distinguish these two? Maybe if you look at focal versus diffuse ST elevation, maybe it will help determine whether it's a non-coronary myocardial injury versus STEMI. We looked at some of this data in our series that we published. If you look at diffuse ST elevations versus focal ST elevations, in patients who had myocardial injury, most of them did have focal elevations, but 60% of patients with non-coronary myocardial injury also had some focal elevations. So it may be helpful, but not completely. What about a history of chest pain? So if a patient presents with chest pain along with anything else, maybe that's more likely to predict they're more likely to have STEMI. In our series, it appears that it does help. 62% of patients who had an MI had chest pain, but only 10% who had non-coronary myocardial injury had a history, came in with chest pain. And finally, does POCUS? You heard from the excellent talk from Dr. Chandrasekhar about the significant increase in POCUS during this COVID pandemic. In fact, in our case, most of the times it would be EKGs and a POCUS sent to our phone from the ER, and we would make our decision whether to take the patient to the Cath Lab based on information not just from the history, not only from the EKG, but also POCUS. And the point of care echocardiogram, interestingly, in our series, what we found was regional wall motion abnormality was actually present in the majority of patients who had a myocardial infarction, and none of the patients who had a non-coronary myocardial injury. So it does seem to help if you have information from POCUS. So this is kind of the algorithm we used, looking at EKGs first and then quick POCUS, trying to see if there is regional wall motion abnormalities on this. What about troponin elevation? In our series, the orange bars are for non-coronary myocardial injury. The blue ones are for STEMI. And what we saw was in patients who had true STEMI, the median troponin elevation was significantly higher when compared to those with non-coronary myocardial injury. What about D-dimers? Interesting data on D-dimer. What we found was D-dimer was significantly elevated in patients with STEMI. It was elevated in those with non-coronary myocardial injury, but less so, as you can see with these numbers. But the other interesting part we saw was the D-dimer elevation. So if you look at non-COVID ST elevation series, only 36% of patients who present with the ST elevation, the non-COVID era, had elevated D-dimer. In our series, in the COVID-19 patients, 100% had significant elevation in D-dimers. And if you look at these outcomes of these 18 patients, it's pretty dismal. If you have non-coronary myocardial injury, the mortality was 90%. If you had STEMI, the mortality was 50%. Now, of course, this was an early experience, in the first couple of weeks after we started seeing many of these patients. So what is the mechanism of myocardial injury in these patients? And of course, as other speakers have also spoken about, in terms of ST elevation MI, it could be a typical plaque rupture. Let's not forget that inflammation increases inflammation and propensity for plaque rupture. There is also hypothesis that there may be coronary emboli. These patients are prone for systemic thrombosis, and potentially it could be an embolic phenomenon. And of course, the stress of infection can also lead to spasm, microvascular changes. There could be potential direct myocardial injury. And let's also not forget supply-demand mismatch because of profound hypoxia. We had a couple of patients where we would see ST elevation when the patients were profoundly hypoxic and disappeared after the patients were intubated and their oxygenation was much improved. And in just a quick two more slides about management of STEMI in COVID-19 patients, we wrote this perspective saying why fibrinolytic therapy for ST elevation in the COVID-19 is not your new best friend. Prior to this, the word from China and other places were maybe we should just be using fibrinolytic therapy for all of these ST elevation patients because you don't want to expose your Cath Lab staff for that. So we wrote this perspective based on our experience from New York, and pretty much questioning should we be really using fibrinolytic therapy for these patients. Let's not forget that in the non-COVID patients, we know data from multiple randomized trials that the efficacy of lytics decreases with longer time from symptom onset. And what we saw in the COVID era was there were substantial delays in presentation. The patients wouldn't come into the ER quickly. Even when they showed up, there was substantial delays in diagnosis and recognition of STEMI. So you can imagine the efficacy of lytics was substantially reduced. In the non-COVID times, the TIMI-3 flow rates were 50 to 60% with lytics. And in our experience, in the few patients who were lysed, we saw substantial lower proportion of patients who actually would get TIMI-3 flow. So therefore, we do anticipate that the rate of recurrent ischemia is going to be substantially increased, and the rate of bleeding is also be higher. And let's not forget that we saw non-obstructive disease in up to 50% of patients. So if you use lytic first strategy, you're going to lyse a lot of patients. So we basically concluded by saying, accepting scenarios of delayed transfer from hospitals without on-site cath facilities, it is unlikely that the inferiority of fibrinolytic therapy to primary PCI would change in an infectious disease paradigm. Whether fibrinolytic therapy is useful to target systemic microthrombi associated with COVID-19 remains to be proven. Until that time, primary PCI remains the best treatment for suspected STEMI, taking full precautions to minimize risk of exposure to the Cath Lab staff. Just to summarize, what we saw was a high prevalence of non-obstructive CAD, and the combination of chest pain symptoms, EKG changes, and focused echo likely helpful to guide decision-making. And primary PCI should still be the standard of care for the management of these patients. And strict adherence to DON and DOF protocol to minimize exposure is critically important. And thank you for your attention. Thanks for having me on.
Great talk, Dr. Bangalore. And I also want to thank every author for sticking to a 15-minute talk, and we have been doing very good on timing. I'll introduce the next speaker, Dr. Bijeshwar Maini. He's a very accomplished clinical professor of medicine and fellowship program director of cardiovascular disease at College of Medicine, Florida Atlantic University at Boca Raton, Florida. Dr. Maini got his education from Punjab University in Ludhiana, India. He finished his residency fellowship and interventional cardiology fellowship at Hahnemann University. Dr. Maini served as a director of Division of Structural Heart and Advanced Cardiovascular Intervention at Pinnacle Health Cardiovascular Research. Currently, he is a national and Florida medical director of cardiology in Tennant Healthcare Corporation. Dr. Maini has over 100 research articles. He's a national proctor for Watchman device, TAVR, core valve, MitraClip, and aortic endograft. He's also a national PI for multiple clinical trials. Without further ado, Dr. Maney is going to talk about structural heart disease and COVID-19 pandemic. Dr. Maney, you have 15 minutes. Thank you.
Thank you, and good evening. Appreciate the invitation to give a talk to AAPI. Let me share my slides here with you folks. You folks can see my slides?
Yes.
Yeah.
Yes.
Perfect. Okay. So I think the elephant in the room is certainly the uncertainty that we're talking about, and three very eloquent speakers spoke about different topics, and all that you garner from is we are certainly sailing in uncharted territory. We really don't know where we came from, where we are, and where we are going. So let's look at that as to where we were at the beginning of the pandemic, and this is what we published a few days ago. And this goes in the vein of what Sripal was talking about, is what we saw was a significant drop in the number of STEMIs that we were seeing in multiple hospitals throughout the country, which, you know, you could be explained by the fact is people were scared. They were probably saying, well, I'm a little short of breath. I'm having a little chest pain. I'm just going to sit at home and chill out and probably not wind up in the hospital. This certainly, we think, we are not sure as of right now, is this probably has had significant connotations on people dying at home. And as time goes on, we'll certainly find more about that. And if you take one step forward here, this is even more, from my perspective, more disturbing is that even if you look at the door to balloon time, the door to balloon time actually worsened. And you might wonder as to why that was. Well, people came in, were having atypical symptoms or were short of breath. You know, the first diagnosis was COVID-19. People were doing CT angiograms and you name it, or they were kind of like trying to say, you know, maybe you ought not to go to the Cath Lab. Everybody was deathly scared of taking these people to the Cath Lab. And as we all remember, PPE was scarce to begin with at that time. And there were a lot of issues. You know, should you be taking these patients in a Cath Lab that does not have negative pressure and so on and so forth? What if you have to intubate these patients? These patients are going to be, you know, throwing up and they're going to get sick on you. We're going to become hypotensive and so on and so forth. So a lot of that had to do with this. So we then proceeded forward to look at the drop in structural heart procedures. This is pending publication right now. And these were the centers that participated with us. And if you look at the graph, this looks like the mortality curve for critical symptomatic aortic stenosis. No pun intended here. This is a structural heart talk. And it seems like the field got completely annihilated. So what happened here? And if you look at the indications for structural heart procedures during this time, the commonest reason why people were undergoing structural heart procedures was one and only was refractory heart failure. Most of these patients were being told, you're doing fairly fair, not the time to come, or I don't want it done because I'm deathly scared to be anywhere near the perimeter of the hospital, which is certainly a problem that we'll talk about in a second. So now, you know, unfortunately, these slides are ever so slightly old, but I want you to understand that when we start looking at the first spike and the so-called second spike, or the second wave of the first spike, however you want to look at it, it seemed like after the first spike, we were kind of like climbing back up. And obviously, the elective procedures took more of a hit than the emergent procedures, but nonetheless. But unfortunately, I don't have data to show you that. We're looking at it right now as we speak, especially for us in Florida. Our second spike has completely decimated our volumes, and people are completely not interested in coming to the hospital for any kind of procedure in which they do not perceive is going to kill them today or tomorrow. And forget about medicine for a second. If you look at Wall Street, so analysts saw 30% drop in tower growth in April, but they felt that Q2 for these companies would be this quarter, and they thought that this would be better, but unfortunately it is not being better, and nobody wants to talk about it right now. And if you look at specific procedures, if you look at the Watchman curves, it pretty much got decimated in the first curve. And when you look at the volumes are kind of coming back towards the end of May and June, things seemed like they were doing okay. And then the second wave hit, and we don't have numbers for that, but I can tell you it has gone down significantly. Obviously, certain parts of the country are doing better, but at least where we are right now in the southern United States, It looking pretty dismal. Now, this is something that people started talking about. Mitral clip cases should generally be avoided because generally people are not trying to die on you when you have severe mitral regurgitation, unlike when people consider severe symptomatic aortic stenosis. So let's look at where the issues are arising right now. So how do we protect our patients, first of all, who are very ill? And this is a new field. And unfortunately, a very expensive field. You all know that these devices cost $30,000, $35,000. So how do we protect both the patient and the field? We do not know how these patients are truly doing at home. They're not even seeing their PCPs. If anything, they are seeing them on telemedicine, which is not the same thing as laying your stethoscope on the patient's heart and their chest to see if they got crackles or not. How many of them are developing worsening CHF symptoms and dying and being labeled as COVID-19? We don't know the answer to that. And I can tell you a few of our patients who came in because they were in CHF to the ER, got COVID-19 testing done and were positive. Well, guess what? You're not getting anything done right now. Too bad. And a lot of other things. How do we continue physician and patient outreach? It's very difficult. You cannot sit down with anyone. And how do we make our patients' comfort level improve for coming to the hospital for quote unquote elective procedures for structural heart? It's a big problem. If you're 90 years old and you are told, you know what, you cannot bring anyone, this person is not coming for any elective procedures, however sick they may be to begin with. So I want to take you through the ACC SCNI position statement that was published very recently. It gives you an idea as to where we think we ought to be. Again, these are clinical decisions that you have to make for each individual patient. So don't take this as gospel truth, but something that you should take as a guideline as it's expected. So somebody who's got symptomatic severe AS, obviously, most of the times we are not sending them home. We're testing them for COVID. Nobody goes to the hybrid OR or to the Cath Lab without making sure that they're COVID negative. And then going ahead and doing their procedure. So now we are really not sending these people home for fear they'll go outside, contract COVID-19, and then now you're sunk at that point. So that's the strategy that we are using, and that's what the guidelines are suggesting as well. If you have minimally symptomatic severe critical AS, now it becomes a judgment issue. A lot of times we're saying, well, you know what, it may not be a bad idea for us to just take care of you while you're here, or send you home with very, very controlled observation. Did you come and see us back in the office? Then we'll get you back in the next week or two, if we could. If you're truly, truly asymptomatic, then yes, you may go home, come back at a time when you feel safe and we feel safe. This is okay. We had started to feel like it was okay after the first spike had passed, but certainly we've gone back into that phase where the uncertainty has come up, and we are telling our patients the same. If you're truly asymptomatic, which again depends on what your mean gradients and such are, then again, there's no great urgency to doing anything. So this is yet another algorithm by which you could potentially treat patients. This was published in the Journal of American Heart Association. And if you look at it, it pretty much is the same thing. So if you're emergent, you got to take care of it. It's urgent, you are better off taking care of it. And if it's truly elective, in this case, what we were initially talking about, asymptomatics and stuff, you're better off leaving them alone rather than bringing for elective procedures. Now, this is something very interesting which has really taken on, and a lot of people are talking about selective same-day discharge. Now, it again depends on which Kool-Aid are you drinking. Now, these procedures in the days gone by, if you remember about 10 years ago when we were in the midst of doing research trials, this used to be a 4 or 5 day ordeal. Each procedure would take half a day to do one TAVR procedure. Now it's a 15-minute procedure. Patients are awake. They all get, percutaneous access, and they're sitting up half an hour or an hour later. So could you technically send them home? The answer is yes. Should you be sending them home the same day? Well, it's yet again a serious judgment call. And what would be the rationale? You really want to protect PPE, you want to protect your patients, you want to protect the staff, and so on and so forth. But before you venture out on this escapade, you have to be very careful as to who is the patient that you're going to choose. So you have a low risk patient, you're going to do transfemoral TAVR. Either the patient has a permanent pacemaker or has no conduction abnormality, no major anatomic, cognitive, or practical barriers, has a very supportive family, is completely with it, lives very locally, like across the street almost from the hospital, or is willing to stay locally at least for one night. Now, this was just published by Christine Chung. Again, the same thing. Low-risk patients, conscious sedation, choose your TAVR device appropriately, no pacemakers. You could potentially discharge these patients home in 6 hours. Again, phone calls, telehealth visit, there's lots of patches that are coming out. We're actually doing a study called the Telestar trial in which we'll be patching these people for a week to 2 weeks time. And we can not only look at their heart rate, but their rhythm, their pulse ox. If they fall down, they're almost falling down, our call center gets notified. So these are certainly options. Again, the same thing from Chung's publication, not only from an aortic perspective, but from a mitral perspective. This is common sense. If you have severe mitral regurgitation, you're not doing well, you really cannot wait. Versus, you have severe mitral regurgitation, you have mild symptoms, you should be treated medically and not be brought on to the hospital for a variety of reasons. Again, understanding that these people will not only get intubated, but will require a transesophageal echocardiographic examination for a prolonged period of time, exposing the operators, and the anesthesiologist and the echocardiographer and a lot of people who are going to be in the room. So again, like the previous slide said, you have significant severe mitral regurgitation, check class 4 heart failure, and so on and so forth, cannot get you out of the hospital. Well, you will be taken care of. Or if you cannot stay outside for a long period of time, we will bring you in and take care of you. But if we're really doing fairly fair, it probably is a good idea to wait. Again, depends on the patient. So paravalvular leaks, again, is something that patients could potentially wait on, but this is one of those categories where sometimes patients are in bad CHF. Sometimes patients are hemolyzing. So if patient is hemolyzing and you're requiring blood transfusions, this is not something that could wait for the next 3 months or 4 months to get their PVL closed. Valve in valve, again, this is a procedure which is to be done very, very carefully. Again, depends on how symptomatic the patient is. You could do it, but if they're doing okay, it's best to wait. And again, there's a lot of resources that are used when you're planning these kinds of procedures. So other structural heart procedures, including appendage closures, these are really elective procedures and they can wait. And we can see that by our volumes of appendage closures, they have really gone down. And I think there's nothing wrong with that. These people will come back. These people are not going to die because they did not get a Watchman device or they did not get their ASD closed, especially from an adult atrial septal defect closure perspective. And certainly from a PFO closure perspective, there's nothing called an emergency PFO closure. Maybe anecdotally, yes, but not really. Intraprocedural imaging, Dr. Chandrasekhar did a great job, so I'm not going to belabor that again. But the idea is wear your appropriate PPE, wear your face mask, make sure if you have to do a TE, and I would completely agree that CT should be supplanting TE as and when it is appropriate. And I think most institutions, including ours, is doing more and more CT rather than, especially pre-op TE imaging for appendage closures. Obviously, intraprocedural, if you are going to do appendage closure, you have to do TE guidance. Now, there could potentially be possibility of doing intracardiac echo, but it's not fully vetted and so on and so forth. But in certain situations, it may be a possibility. Outpatient clinics, again, usually for structural heart clinics, a lot of people have to see the patient, not only you as a cardiologist, the echocardiographer, the heart failure specialist, the surgeon, and you name it, people have to see the patient. So trying to minimize patients coming to the office is very important. If they're going to come, minimize the number of times they have to come, lump their studies together. We have really, really gone away from doing coronary angiograms. We almost never do them unless the CTA shows significant coronary disease that we really need to rule out, especially in lower risk patients in whom we might suggest surgical revascularization and SAVR versus TAVR. But if you are an extremely high risk patient, even if you have disease and you're not having any symptoms, and we think your symptoms are because of aortic stenosis, you're probably just going to do the TAVR and treat your coronary disease medically. So something to be very careful about as to who comes into your office and how many times are they going to be brought to the office. Clinical trials for structural heart are, for all intents and purposes, have really slowed down. We are enrolling very carefully. We hope to get restarted again with a lot of fervor, but again, this is something that should be put on hold and if not slowed down significantly. And lastly, but not the least, is the stage of the pandemic. You are in, which geographical location you are in? Are you in Florida? Are you in New York? Are you in California? Where are you in your local geographical situation? What is the condition like? What are the local state rules and local rules that are affecting you will and should dictate as to how you should treat your patients appropriately. Now, this is something I did want to bring up. You know, any kind of issues that happen always brings out innovation. So this was something that we had always spoken about. We could see somebody else's cases, proctor them through difficult cases and so on and so forth. So this has become more of a reality, which is a great thing, and I think will last in the future. Something very good for training purposes and for seeing patients learning and so on and so forth is certainly here to stay in my mind. Now, again, going back to the financial side of things, like I was showing you, now Edwards has dropped their 2020 revenue guidance due to COVID-19. So this is going to impact not only us in the hospital, it's going to affect the medtech industry, it's going to affect the pharma industry, and so on and so forth. We don't know to what extent it's going to affect us, but so far it seems like there's going to be a downtrend, especially from a financial perspective. So I did want to bring this up. This is the daily death rate as of August 3rd, 2020, and you can look at the different color in which state you're at as to where you stand as of right now. And this is open for debate at this point in time. We don't know which way COVID-19 is going. And my hope is that we are in the green line and not in the orange or a salmon colored line, because if we are on that track, that certainly does not bode well for any one of us, no matter what field of medicine or whatever walk of life we are in. So whether that's because of PPE, universal precautions, or the natural disease progression, or this pandemic wave that is going to last for God knows how long, will dictate a lot of things. And the big question is this our future? Is this how we're going to be dressing up every time we go to the hospital? Or are we going to go back to good old times as to how we used to interact with our patients? And I truly hope that we go back to our usual ways of treating our patients, and then hope this pandemic is behind us soon. Thank you very much.
Thank you, Dr. Maney, for that excellent talk and 15 minutes. And next speaker is Dr. Prasad Chalasani, a good friend of mine for more than 30 years. He graduated from Andhra Medical School, was there at PGI Chandigarh briefly, and came to Atlanta and did his training at Emory University School of Medicine. Currently, he's working at Florida Heart Center as the Chief of Cardiology at Lawnwood Regional Medical Center and Heart Institute. He's also a Clinical Associate Professor of Florida State University School of Medicine. And his special interest is in structural heart and also coronary evaluations. He is also board certified in other fields also. Dr. Chalasani. Dr. Chalasani ready? Okay.
Thank you, Sunil. Thank you for the organizing committee. So I'm going to wrap up this webinar. I'm going to share my screen. Okay. So effects of COVID-19 on cardiovascular services in hospitals. There are a few of the slides were discussed, but I'm going to be spending a little bit more time. A lot we know, a lot I have a current data. So that's where we'll be spending next 10 to 15 minutes. So I just want to recognize my guru, Dr. Willis Hurst and Dr. Spencer King, who I had privilege to be trained for about 7-8 years in Atlanta. They were great people, and they really, not only the science, but also they taught me how to be really human treating the patients. So going back to this slide, this is a slide where we can see the disease of the trends of COVID-19. This is the first spike we were talking about in the New York, New Jersey, and Chicago, California, and this is where we are in Florida. And this is looking at the daily trends in the mortality. In fact, though the prevalence was higher in the later part, but the mortality was much higher during the first phase of COVID for various reasons, which we all know with the treatment options and know how to treat these patients, not to ventilate and steroids and whatnot. So this is the data from Florida, which Dr. Brismani was talking about. And this is the COVID positives. We can see this is July, end of July, and then August it started slowing down. And these are the PUIs, and this is the ICU admission. These are the things we track every single day in HCA hospitals that where I work with. Next, going to what exactly COVID-19 has done. This is from the CDC Gov. In the first 10 weeks after the COVID-19 declaration of emergency, there's a 23% reduction in heart attacks and 20% reduction in the stroke. And of course, some diabetic patients, but that's pretty significant reduction in the emergency room visits alone. And this is it's the same graph. If you could look at it, you can see a dip. This is where the starting of the COVID, and as we see that later part of the first phase, we started getting back some of the patients back to the ER. This is an absolute decrease in number of ER visits based on the sex and the age group. If you look at it, the reduction in the males is much higher during the age of 55 to 85. I think this constitutes most of the patients who did not make it to the ER, even though they had either myocardial infarction or strokes. So next, talking about the activation of the STEMI teams. Sripal has touched a little bit, and a lot of the places in the country, they were debating in ST segment elevation to activate or not to activate. So this is a study done using 9 high volume Cath Labs, where they have to do at least 250 STEMIs a year between the periods of January to end of the March. If you look at, I'll show you the graphs, there's a 38% reduction in STEMI activations. And they were doing more than 180 STEMIs every month compared to 138 during the COVID first phase. This is the STEMIs, if you can see it. And this is the January, February, and March, you can see it 138. So if you look at per center, they were doing about 25 STEMIs a month. And then during the COVID time, they were doing 15. So not only the patients did not show up to the ER, even the activation and taking to the Cath Lab because of the fear in the early phase really impacted some of our decision making. And I'm going to jump on from the ER to different hospital admissions and how the volumes have impacted the hospitals. And I picked up Kaiser and HCA systems. The Kaiser Permanente is in the North California, and they have 21 medical centers and 255 clinics, and they have a large population basis. If you look at it, the gold is the 2019 acute MI, and this goes to March, April, and the later part of the April. And the brown one is the acute MI during 2020. So there is about 30 to 35% reduction in acute MI in the hospitalizations. And this is where the COVID first started, and this is where the shelter in place in California. So as the cases of COVID started increasing, the ER visits and the hospitalizations for acute MI decreased by almost 30%. And HCA is where I have a lot of the data. That's where I work. I was able to get very current data all the way up to middle of August. This is a very large US non-governmental healthcare, and they have 84 hospitals, 48,000 beds. They have enormous centers all over the country. And so this represents a little bit like a global picture of non-governmental hospital setup and their data, how it comes. These are the group of people who helped me to make these slides, because this is not a publication, this is internal data, and they were kind enough to let me use this. So this is the inpatient cardiac admissions. It's a nationwide for all the HCA hospitals around the country. If you look at during the peak time, this is the first phase. There was a 47% reduction in all inpatient cardiac admissions, 268,000. And if you look at now, this is in first week of August, about 10% reduction. So pretty much we came back to, compared to 2019, but now we started seeing a dipping. But even though the number of COVID patients are higher, the ICU occupancy is higher, inpatients are higher, but still, I think the cardiac admissions kind of gotten much better compared to 47. I think the scare fear and hospitals have now established different pathways where to keep the COVID patients and how to take care of the non-COVID patients. So I think this is a good sign that we're not really panicking, and we are trying to take care of the patients in the hospital setting, even with a high COVID presence. And these are the inpatient hospital admissions in the Florida, East Florida, same, about 50%. But this is the most important thing of what Bridge didn't have the data. This is as of August. We are 32% down in Florida compared to the nation, where it was only 10%. So Florida being the epicenter in July and August, we have seen a very tremendous decrease in hospital admissions for cardiac admissions. And these are the heart failure admissions in the national. There's a 50% across the country during the first phase. And now they're about 25% reduction in the admissions across the country. And this is the Florida, 41%. So still, Florida is not ready to accept many patients. Still patients are staying home, or hospital admissions are definitely much lower. These are the Cath Lab volumes. Cath Lab volumes went down 58% during April, March, later part of the March and April, and now we are 14%. This is a national data, all comers at all the hospitals. And this is Florida, 34%, and now we are only at -3%. So this is very different than what we expected, why the Cath Lab volumes have pretty much comparable to 2019. A lot of the doctors have started opening their offices, and they're doing the stress labs. And so a strongly positive stress test obviously can't wait, and they were doing more procedures. So hospitals like where I practice now, we have the methodology. Everybody gets a pre-procedural COVID, and we have a totally separate place of recuperation, and everybody goes home on the same day. Very rare that we even keep a STEMI 24 hours nowadays. If they come in the morning, if their troponins are not really bad, we send them on the same evening. So definitely we have improved how to handle during the pandemic in the second phase, so that our methodology and our handling of these critical patients is improving. And this is the EP volume, definitely taking a hit, 58% nationwide, and they're much better in the nation. But in Florida, still very low, 38%, because a lot of the EP procedures are not necessarily emergencies, so we cannot justify an AFib ablation or an elective SVT ablation during this pandemic in the second phase. So EP is lagging behind compared to the acute coronary interventions. These are the surgical volumes, as I can say, pretty much down 50%, and nationwide 30%. The more dramatic is in Florida. Look at 55%, still surgeries are very low in Florida, 55%. And we had an 83% reduction in the first part of the first phase in March and April in East Florida. These are the structural volumes nationwide, 34% in HCA systems and 3%. So we're caught up. But I think this is not really catching up. The structural volumes in 2020, if you see, before this were much higher. So they were about 15, 20% higher. with all the new centers being opening for the TAVRs, mitral clips, and left atrial appendage occlusions. So we are basically reaching where we were 2019. So we haven't seen that 20% hike, which we expected during this time in 2020. So still we are lagging behind. As Dr. Mani has said, not many procedures in structural side have to be urgent or emergency. So same thing in East Florida, we see a little bit hike. This is the most fascinating thing. So with all this said and done, are the people dying more often at home because of the COVID? This is a study that showed out of hospital cardiac arrest. This is from Italy data. I don't have the data from US, but they took out 4 counties or 4 areas, regions, and the blue and the gold. The gold is in 2019, and the mortality in blue out of hospital cardiac arrest. So you can distinctly see during the COVID phase, out of hospital cardiac arrests are much higher. P-value is very, very significant. So in conclusion, ladies and gentlemen, total cardiovascular admissions during COVID-19 decreased significantly. Cardiovascular out of hospital mortality increased significantly, as one would expect. And all the procedures have decreased significantly. And I think we're catching up in most of the places because of the various new modalities the hospitals are trying to cope up with, and most of the PPE being available, and a lot more screening for the COVID-19, and having a different set of place for these patients to be recovered. Cardiovascular surgeries also decreased significantly. Though COVID-19 cases have trended upwards significantly in the last 30 days, cardiovascular volumes have not shown the same decline as seen in the first phase. I think that's a relatively good sign. So I want to thank you, mainly the AAPI leadership, for allowing us to make this webinar. And I want to really thank Dr. Basu Ray and Dr. Chandrasekhar, Sripal, and Bridge Mani for coming today, accepting my invitation. And it was a very nice meeting. Thank you. And thanks for all the organizers and the moderators. Thank you once again.
Thank you, Prasad. That was an excellent presentation. And I have one comment, and I'm going to ask the questions after that. My comment about this volumes going down during the first spike, I think was partly because we did not have the testing at that time. And second was PPE availability and conservation of the PPE. And I also work at the HCA hospital. They pretty much asked us not to do any elective procedures for a month or month and a half. So that dropped the number significantly. And as July, August came, we had PPE and we had enough testing facilities available, and test was coming back quickly. So the volumes have come up. I think that is a big difference compared to April and August 2nd spike. What do you think on that?
I think that's a very good point. I think there's 2 factors. One, I think all of us were scared in the first phase because the mortality was very high. Patients were in the ventilators. We didn't have the treatment options. And of course, the hospitals were not really ready to handle elective cases or semi-urgent cases. Now things are totally different. I think we are in a different phase. Things are much better. We understand the disease process. We have a lot more screening, a lot more PPE. And of course, we are also less stressed out about the ICUs and mortality. So I think both psychological factors and physical factors made a big difference in the difference in spikes.
Thank you. There was a question about corresponding increase in mortality as the procedure volume went down. I think you already answered that, and other speakers also have answered that there is increased mortality, obviously, in Italy, and we don't have the numbers in US. The other question was about structural. If symptomatic aortic stenosis, would COVID positive make any difference in management except for additional precautions of the medical team? Anyone who structural doctors?
Dr. Mani.
Can you guys hear me now?
Yeah.
Yes.
Yeah.
Oh, great. So I hope I understood the question correctly. So for severe symptomatic aortic stenosis, we know the mortality is very high, especially if you let these people go home who are admitted to the hospital. So taking care of them while they're in the hospital is probably the prudent thing to do rather than waiting. And because if you send them home, all that's going to happen is they're going to wind up back through the ER with symptoms, and then again the whole process is going to begin.
Thank you.
Great. One more question. For Dr. Chandrasekhara and Dr. Basure, if they are still present, the mechanism of myocarditis, maybe there are some variation. However, but what is the long-term implication for myocardial scarring? Would they have to worry about cardiac arrhythmia in the future or not?
Yes. So any scarring in any person, whether COVID or not, is associated with a bad prognosis, right? It's like troponin. You get a leak, there is a slight excess in mortality over the long term. What we don't know is whether this scarring is reversible or not. In acute myocarditis of the classic variety, a portion of the scarring that we see initially becomes smaller with time. And those patients seem to be doing much better than people in whom the gadolinium area doesn't get smaller. So at this stage, we don't know about various series have anywhere from 10 to 30% of patients have some small gadolinium in their myocardium. We don't know how that will turn out because the longest follow-up we have, so the paper that we were talking about was about 70 days, 60 days after recovery, maximum was 90. Now there is a paper that we are just reviewing, which is looking at about 5 to 6 months after COVID. And it also seems to show persistent scar. So if this scar keeps staying there, we might find some sequelae down the road.
Are these like other viral cardiomyopathies that we have seen before, or is there any difference with regard to the MRI pictures?
It seems slightly different, not on the MRI side, on the fact that other myocarditis, you can show myocyte damage in the areas where there is infiltration. In this particular condition, you don't see virus in the myocardium, you don't see myocyte damage. So a lot of us are starting to believe that the myocardial depression is cytokine mediated rather than loss of cells.
Thank you. I have a question for Dr. Bangalore, Sripal Bangalore, with regard to the STEMIs. Do you all use the negative pressure room in the Cath Lab, or is it the routine Cath Lab with the normal circulation?
Yeah, great question. So, so we do have, the labs are not built with negative pressures. So what we had was, in some of the labs, we had HEPA filters. In other labs, we had a dedicated Cath Lab for STEMI. So once we are done, like the Cath Lab is out of commission for at least 90 minutes till everything is cleaned, etc. So, but the Cath Labs were not built with negative pressures.
Yeah, I don't know what our interventional colleagues would feel about this, but our engineers told us it's not a good idea to convert it into negative pressure.
Right.
They converted a lot of our makeshift ICUs into negative pressure, but they purposely said you don't want to do that in the Cath Lab. I don't know what you guys think about that.
It's anybody's guess right now, but the one more other question for Dr. Bangalore is, what do you think is the mechanism of ST elevation in the people who actually do not have occlusive lesion in the coronary arteries? Because when you have an occlusive lesion, there is an electrophysiologic explanation for ST elevation, because you lose the voltage from the whole myocardium. Supplied by the coronary arteries. But what do you think without occlusive lesion, you have a ST elevation?
Yeah, I think that's a great question. So, we have seen in one of the slides, as I showed, it's likely multifactorial because as I was saying, we also have seen this global ST elevations in patients who are profoundly hypoxic. And once they get intubated and their oxygenation improves, their ST elevations get better. So we have had this transient ST elevation developed in a couple of patients. I think in other cases, it is possible that one of the hypotheses is are there coronary microthrombi? So in other words, the epicardial arteries look okay, but are there actually clots in the microvasculature? Could it be spasm? Could it be just a global supply-demand mismatch? And finally, I mean, although, I mean, there are, the question about myocarditis comes back. We have also seen patients who presented with the Takotsubo-like picture, like, normal coronaries. And we have had patients who went on tocilizumab and stuff, and like after 10 days, their EF completely normalized. So we are seeing the spectrum. So I think the short answer is it's multifactorial. I think we are seeing many different reasons for this.
Great.
One of the things I do want to make one comment is that with all this, whether it's myocarditis of whatever variety it will wind up being at the end of the day, I think we as cardiologists have to remain very vigilant to follow these patients very carefully. And as I think one of the speakers was alluding to, is even talk to their loved ones who were COVID positive and to follow and were not very symptomatic, to follow them and make sure that these people are not going to develop cardiomyopathies down the line. And hope that's not the case, but we don't know the answer to that. And the jury is still out. And again, as I said, we are living in very uncertain times, and we don't know what the next few years are going to bring as an aftermath to this pandemic.
Yeah, one of the things that I also want to highlight is the fact that there are a lot of patients who are very scared to come to the hospital. And, as a number of speakers showed, increase in out-of-hospital cardiac arrest. I mean, we had patients who were actively having a stroke, did not want to come in. I mean, so I think there needs to be more awareness. I mean, if you have symptoms, I mean, it's better to seek medical care, because the mortality out of hospital cardiac arrest is pretty high. And part of the reason is this fear of coming into the hospitals. I mean, which is understandable, but now I think many of us are pretty well equipped in making sure that, we ourselves have taken care, and also to make sure that, patient-to-patient transmission doesn't occur. We are taking all precautions.
All right, I guess there is one more question popping up. I think then we can wrap it up if there is no more questions. Is there any difference in a volume in between countries with socialized medicine and US? I think Dr. Prasad wants to take on that one.
Problem with the socialized medicine countries are, England is a classic example. And when they did the lockdown, their electives are 0. So when your private hospitals, they find a ways to, I think if you take off the first phase, that's how the England is even today. Like for example, Manchester, all my friends are, they're pretty much at home. They haven't done any elective in the last almost 4 or 5 months. And whereas here, I think after first 2 months, we started going back to the hospitals and offices, and we found various ways to get back to work and do some active, both urgent as well as elective cases. So definitely, as you can see, in the next 3 to 6 months, we're going to come back to, if not close to normal, compared to socialized medicine countries.
Thank you. Any final comments from any of the speakers?
I just want to make a couple comments on a longitudinal, as everybody suggested. The key is a lot of the patients who survived, who are on the ventilators, are really sick. Some of the young people, they have a persistent pulmonary problems down the line with the pulmonary scarring, as we know. And when they come with the short of breath, I think a periodic echocardiography as we go down would be the simple imaging. Probably would help, probably MR down the line. And the key is the amount of the scar tissue that becomes an issue. If they don't have a real myocarditis, if it is all a chemical myocardial injury, and that myocardium improves and the LV function normalizes, hopefully they should have a good prognosis, both arrhythmias and long-term heart failure. I think that's what, as a cardiologist, we're hoping for the best from this COVID.
One of the things that's going to be the next big thing that we have to deal with is when do you allow these people to exercise and go back to doing activity? So we've had a lot of Division I college level athletes who have had small scars in their heart after COVID. And we also have some major league basketball and football players who are coming now and saying, when should we do it? And it's full of all kinds of political equations. The president of the university wants to know when we can clear people, and the major league games want to know. And we don't have the answer. So we really don't know what to do. We are just flying by the seat of our pants. So I'm sure all of you will see that too.
Yeah.
Yeah, that is a big question that we are facing here also.
Right.
And I'm just telling them arbitrarily, there is no data, but my recommendation is 3 months. I'm telling them.
Correct.
So at that point of time, re-imaging, putting them on a treadmill and see how their exercise capacity is.
Exactly.
And then I will determine.
Right. Good discussion. Very good discussion.
Any other speakers have any final comments? Thank you very much. Sudhakar, are you there for vote of thanks?
Yeah. Thank you very much for an excellent webinar to our members. I want to thank you, Dr. Basure, Dr. Chandrasekhar Garu, Dr. Bangalore, and Dr. Brijmayani, and Dr. Chalasani for your time. And we thoroughly enjoyed the discussion today. Thank you again. Good night.
Good night.